Welcome to the 274th of the COVID calls. This is a daily discussion of the COVID-19 pandemic with a diverse collection of disaster experts. My name is Scott Gabriel Knowles. I'm a historian of disasters at the Korea Advanced Institute of Science and Technology. I'm coming to you live from South Korea. Today, I welcome Sharif Elnahal, President and CEO of University Hospital in Newark, New Jersey, the principal academic hospital of Rutgers, New Jersey Medical School. Just a reminder, you can catch COVID Calls live most weekdays at 5:30 p.m. Eastern Time and many Fridays at 5:30 p.m. Korea time on YouTube. Just go to the COVID Calls YouTube channel to watch. You can hear COVID Calls anytime recorded as podcasts on Spotify, iTunes, Podbean, or anywhere you get podcasts. You can also keep up with COVID Calls via Twitter using the handle @US of Disaster or @COVID Calls. Please do help spread the word and send suggestions for future guests and future topics, and please feel free to suggest yourself as a future guest. As of today, May 10th, 2021, there are 3,294,966 deaths globally from COVID-19. That's according to the Johns Hopkins University Coronavirus Resource Center. The death toll in the United States is 581,756 lives lost from COVID-19. In India, they're now reporting 246,146 deaths from COVID-19. Ordinarily, I would read an obituary in this time, but I'd like to move ahead to my conversation with my guest today, and I will make obituary available that I was going to read for today. I'll make that available on Twitter. Okay, I'd like to turn to my conversation for today, and let me introduce my guest. Dr. Sharif Elnahal is an American physician who served in various healthcare leadership capacities in both public and private sectors. He was the 21st commissioner of the New Jersey Department of Health in the state of New Jersey as a cabinet official under Governor Phil Murphy. He now serves as the president and CEO of University Hospital in Newark, New Jersey, the principal academic hospital of Rutgers, New Jersey Medical School. Previously, Dr. Elnahal was appointed to the White House Fellows Program by President Barack Obama in 2015. In this capacity, he served in the United States Department of Veterans Affairs, where he co-founded the Veterans Affairs Innovation Ecosystem, a network of innovators and implementation professionals across the United States who develop and scale best practices that have improved healthcare quality, women's health, mental health, and substance treatment, and other areas, the results of which have been published in the Journal of the American Medical Association. He also served as the Chief Quality and Patient Safety Officer of the Veterans Health Administration, the largest health system in America. Dr. Sharif Elnahal, thank you so much for making time to join me on COVID Calls today.
Thanks for inviting me, Scott.
I'd like to start the way I usually do, just find out where you're calling in from, what the pandemic situation looks like there, what the vaccination situation looks like there today.
Thank you. So calling in from Newark, New Jersey, the community we proudly serve, as well as the surrounding town in Essex County, New Jersey, and the surrounding region. We are seeing a much better situation with the pandemic than just several weeks ago in terms of daily cases and daily deaths. And so I think we're tracking across the entire country and seeing around a 20 to 30% decline over the last 2 weeks in cases, and with deaths, certainly a plateauing, if not reduction, from the previous week, about 5 to 10%, depending on the day that you look at it. And so we are seeing positive trends. I think that's entirely due as a state to the vaccination effort, given that we are up against B.1.1.7, the UK variant, being the strongly predominant variant in our state. And I think that's the case now in pretty much every region of the United States as well. And so we are seeing and mirroring the national trends there in a positive way. Unfortunately, in Newark, we're not seeing nearly as much vaccine uptake as the rest of the state and as the rest of the country. Only about 41% per the latest data that I saw have gotten at least one dose of the vaccine in this community, and even fewer people who are fully vaccinated. And so that's a major effort that we are undertaking as the public hospital that serves the region We just secured 3 mobile vans from the Department of Health to bring vaccine to the community closer to where people are. That should hopefully help. We've also rerouted our vaccination strategy. We used to have 6 lanes of opportunity where people are vaccinated on our campus. We reduced that to 2 lanes and bringing much more of our vaccine stock into the community. And so I think that's going to be the challenge that urban communities are facing, in addition to rural as well, which is also an under-vaccinated area of the country, but certainly seeing that here in Newark as well.
Just to follow up on that, if I could briefly, so that low percentage compared to the rest of the state of vaccine uptake, you owe that to just physical proximity, hard for people to actually get where they need to be vaccinated.
I think it's an issue of equity and the fact that more people in our community are working people. The fact that they have to show up to work, essential workers, makes it more difficult for folks to take time off to get the vaccine and then maybe another day or 2 off to contend with the side effects of vaccines. There's also a phenomenon now where we're seeing a younger, healthier population that remains to be vaccinated. So there's a little bit less motivation, even if there isn't a problem or an issue overall with the science or the vaccines themselves. This is an overall less motivated segment of the population that we're dealing with here. And so I think, again, communicating better what the benefits are and the risks of inaction. As human beings, we tend to underweight the risks of inaction and overweight the risks of action. And so I think a lot of that needs to be better communicated and better endorsed by trusted people at the local level.
So if we could just go back a little bit and pick up a little bit of your sort of previous training, and we can't, you've had so many interesting positions, we can't probably pick up all of it in this conversation, but I did want to ask you this question. In your various roles and in your medical training, what have you done that you feel like has prepared you for this last 15 months?
You know, I think it was really being in the position of state health commissioner right before this. Of course, we weren't contending with COVID-19 when I was in the position, but we did have situations of viral outbreaks. We had measles outbreaks in New Jersey because of a largely under-vaccinated segment of the state that kept getting measles and spreading measles. And I was working hand in hand with the New York State Health Commissioner on that issue. We also had localized facility outbreaks that were significant. There was an adenovirus outbreak that really overtook a pediatric nursing home in the northern part of the state. And so having had issues and challenges to contend with in that position was certainly helpful as a matter of perspective in dealing and running the state hospital and dealing with the pandemic in this community.
And I know dealing with the opioid epidemic was one of your major areas of concern as well. Can you speak a little to that, how focus on that epidemic might have given you some insights in how we might think about dealing with this COVID-19 pandemic?
I think they're definitely related. The opioid epidemic was probably the #1 public health issue when I was health commissioner, and the need to mobilize the will, the funding, and the manpower to really respond to that issue was a big challenge. And it was a whole of government effort at the state to be able to contend with that. I had great colleagues in the governor's cabinet to do so, but it was still difficult to integrate efforts and ultimately execute on that mission, even though we're seeing signs of progress. I think the similar issues are in play now with COVID-19. And so that, as a matter of just practice, was similar. I also think they're related. So, the diseases of despair, frankly, went up significantly during the worst of the pandemic, mental health, behavioral health, morbidities, but also drug use, and other issues like, sexual assault and, domestic abuse. All of those things, unfortunately, increased during the pandemic, commensurate with the need to stay home during major parts of it, and not being able to fully integrate in society again as quickly as people would have liked. And so I think we're going to be dealing with that aftermath for quite some time.
Thank you for drawing out that connection. I think that's an important one. I guess I have sort of a basic question about health inequalities. Is New Jersey facing worse situation there in terms of health inequality than other states of its size? Help us understand a little bit sort of how health inequality works in a state as complicated as New Jersey.
Yeah, it's a really good question, and it was something that I very much focused on when I was health commissioner. So, New Jersey does boast some of the best public health outcomes in aggregate in the country and in the world. Infant mortality is one of those examples. But when you have a situation where Black infant mortality is 3 to 4 times higher than the general population, you cannot claim victory at all on that effort. The fact is, we still have major areas of the state and major localities where things like infant mortality and Black infant mortality in particular, but also maternal mortality even. You don't expect as many women to die in childbirth as they still do in 2021. And unfortunately, rates of death during childbirth are fourfold to fivefold higher in the Black communities that we have in the state. And so we're in the center of that here in Newark. We do a lot to try to extend access to prenatal care and care more generally for folks with chronic disease. These issues aren't just limited to maternity care. They're frankly span the whole gamut of chronic disease in terms of the disparity. And so I think the fact that so many of the areas of the state are still racially segregated, unfortunately, has a lot to do with this and the generations of systemic racism that led to it. And so affording better access to healthcare and access to resources in the communities that need it the most are the first most important step we need to take.
I wonder if it's hard to get that argument across, because what you've just been describing is something that I've heard some people characterize as, well, that's not in the bounds of medicine. You're talking about structural issues, poverty and things like that. I wonder if it's always so clear to policymakers and others that what you've just described is a situation that goes beyond just what happens in the clinic.
Yeah, well, what I'll say to that is that we have no choice at University Hospital but to take a broader and broader role. The fact is, the lives that are in most despair and the most downtrodden end up in one of two places in this community. They either end up in jail or they end up in our emergency room as the public hospital. And so we really have the moral imperative to do more and more for people. Connect them more meaningfully to social services that they already qualify for, enrolling them in health insurance, housing the homeless. So we're about to announce a major partnership with a developer here to create 10 units of supportive housing to put our sickest homeless patients in them to provide wraparound healthcare services in the home, in addition to a clinic that will serve the entire community, which is a voucher-supported housing community from the Department of Housing and Urban Development. Secretary Fudge was just here in Newark visiting this community. And so really happy to see that there's a lot of mobilization on this effort, but we don't have a choice. We have to do this. And frankly, everybody would benefit, of course, the beneficiaries, but also the hospital in terms of creating capacity needed to really treat acute conditions rather than contend with social issues for so many patients who occupy a bed. So I think the value proposition is there beyond the fact that it's the right thing to do. And hopefully that will spur enough support to be able to make progress on these issues.
Thanks for that. I wonder if you could just tell us a little bit about University Hospital more generally. For those who may not know or listening, who may not sort of have a good handle on what public hospitals do in America, how many of them there still are. I think, in my own mind, I'm not exactly clear what that ratio might be these days between public hospitals and other types of healthcare providers. Can you tell us a little background about it?
Yeah, I'm really glad you asked about that because a lot of folks don't tend to know what public hospitals do for them. And so a direct benefit that our public hospital does, and you'll find this as a pattern across many essential hospitals across the country, is that we serve as the level 1 trauma center where major injuries go regardless of the cause. So whether it's a car accident or a gunshot wound or a stabbing or what have you, a major physical trauma comes here as the level 1 trauma center. We have some of the best surgeons and support teams for them in the entire country right here in Newark and in our hospital. So you could need us, and we hope that you don't. But regardless of where you live, that's an important service that we provide. And it's often the case that public hospitals serve that function. And of course, the essential mission of caring for the most vulnerable. The fact is we have far and away the highest charity care and Medicaid payer mix, far greater than any other hospital in New Jersey in aggregate. And you do need safety net institutions to care for the poorest and most vulnerable. Of course, we want to build services that attract folks of all payers and insurances to be able to finance and continue the effort here at University Hospital. But the fact is, we will always and proudly carry that mission. And you do need strong public support for institutions like this to care for the most vulnerable. In a vacuum, the methods of payment for patients who are poor are not enough to be able to sustain the hospital business or the FQHC or what have you. And so you do need subsidization, and you do need a strong role for government funds to be able to maintain these institutions. And so we've gotten grateful to have gotten more support from the state in the last couple of years. We still, vast majority of our revenue comes from patient services, and so we still have to do everything we can to be an efficient organization. But even after you've maximized those efforts, the need for state support and government support is still clear.
Just a reminder, you're listening to COVID Calls, and I'm talking to Dr. Sharif Elnahal, the president and CEO of University Hospital in Newark, New Jersey today. Sharif, I wonder if you could take us back to the beginning of the pandemic, and maybe even when it sort of first entered your consciousness, when COVID-19 first arrived on your daily brief, and what you started having to do there to prepare the hospital for that.
I remember getting a phone call, Scott, from the state health commissioner in January of last year saying that there was a concern about folks traveling from China, when at the time, Wuhan was really one of the only places in the world that had a major issue with this disease. And so we actually quarantined the first patients suspected to have COVID-19 from incoming ships and airplanes. And so we were contending with this issue well before you had documented community spread of COVID-19 at all in the United States. And this isn't a role that is foreign to us. We've been there supporting the state and all of its residents since we existed because of our role. Again, part of the role of public hospitals is to be there for emergency responses, not just locally for a single individual who gets hurt, but overall disaster response. So we were there at 9/11, we were there in Superstorm Sandy, Ebola, and everything in between. And so this was the next crisis that we were on the front lines dealing with. In fact, we helped set up the Secaucus Field Medical Station in New Jersey, the Javits Center of New Jersey at the time. We were in the New York metro area and got hit. We were in the global epicenter at one point. And so we helped stand up that hospital. We helped coordinate transfer and management of patients across all of the hospitals in the northern region. We were assigned that role by the health commissioner and by the governor. We proudly took that mantle. And we provide EMS services at baseline to the city of Newark and Newark Airport. So we do have the infrastructure to be able to deal with the response more broadly than just our community. And so we proudly played that role.
Is it something that you had practiced for? I mean, I don't know how one practices for a pandemic of this scale, but what kind of preparations had gone in ahead of time to begin thinking? I mean, even just that list, you moved quite quickly through a list. And as you were saying, each one of those things, it sounded more complicated, each one you listed. So how do you prepare for those things?
Really funny you asked that, because I often try to rewind and replay how we made decisions. We couldn't rely on anybody who had experience with this, because nobody alive has experience with a pandemic at this scale. The last time it happened was over a century ago. And so we were really looking at classic playbooks for how to potentially deal with a pandemic, but there are so many issues that come up that cannot possibly be predicted. I would have never thought that we would have had to stand up a makeshift hospital in a convention center. But we did that because the state needed to do that, and they asked us for our help. And so we were right there alongside members of the National Guard. The U.S. Army Reserves had to come and assist at my hospital because my staff were so thinned out and strained at the worst of the pandemic, with all the call outs that was needed because our own employees were getting sick and had to contend with ill family members and the like. And so all of that was happening at once, and we had to do what continuously learning organizations do best, which is be humble, learn as you go along, and make the best decisions with the information you have. And I think we did that because I tried to set the right mindset from the beginning. We have to try things. If they don't work, we have to pivot quickly. this is crisis management. It's not business as usual. And so we don't have the time to pilot and then scale or do excessive data analysis on everything we do. We have to do the right thing at the time that it happens. And so I think we did emerge with an overall good result. But remember that because cities like Newark just have a worse infrastructure than places that are more wealthy, and all of the other reasons combined around systemic racism, outcomes were much worse overall for people of color, Black and brown residents here. COVID was the #1 cause of death in those demographics, as opposed to #3 in the general population. So despite everything we did, because of these systemic issues, outcomes were overall worse in Newark.
Can you tell me a little bit about the types of stresses that you began to see? You mentioned your team and the essential workers there, that working in the hospital, who are also members of the community and who also have their families that they had to care for. How did you approach that, even just keeping track of the kind of toll on the physicians and the nurses, but also everybody who's working in the hospital system? How do you keep a handle on the stresses they were under?
Yeah, it's a very important point, because this is, as I keep saying, a crisis that nobody has ever seen in their careers by definition. And so, it did lead to post-traumatic stress in a lot of our employees. Some folks were scared to come to work. Vast majority came to work anyway, despite being scared. And so it speaks to the heroism of the front line and everybody who supports them here, but ultimately does take a toll. And so we set up multiple programs to be able to contend with that. We had psychosocial support and counseling coming from our Department of Psychiatry to any employee who needed it. We have a very successful peer-to-peer counseling program that literally brings people from your job description, or not, depending on your preference, elsewhere in the hospital, who's gotten through a difficult period, so that there can be that one-on-one identification with what folks are feeling and hearing. And none of that is influenced by management at all. These are organic conversations that happen in a safe space. And there was also virtual chaplaincy services. If that's an important part of your life as an employee or a community member, we had sessions with our chaplain that were faith-oriented to help people get through this time of stress. And so we really tried to provide a menu of things that could apply to different folks. But across the board, I'll just emphasize, Scott, that this was a really difficult time, and continues to be difficult because people are fatigued, and we're already dealing with a situation of rampant burnout in the medical profession before this, let alone the pandemic. And so I think it's important to understand that workforce and the strain on the healthcare workforce remains the biggest systemic risk in American healthcare.
I'm glad you put it in that context, because I've been pretty worried when I see headlines that use terms like post-COVID. I wonder about that. You're concerned that when the numbers go down, which of course everyone wants that, and vaccinations go up, that people don't somehow forget the stress and strain on the essential workforce, on health facilities like University Hospital. It's a bit of a catch-22, because you want people to be healthy, you want to get past this, but at the same time, you don't want to forget it too quickly. What's your approach going to be?
Well, on the whole point about not forgetting it, we have to do as a country, a 9/11 commission style analysis of what happened on preparedness. Should be incorporating everything from supply chain to, again, the risks on the human capital and healthcare workforce in this country, and how prepared and rather ill prepared we were to deal with an emergency of this magnitude. But also, how to be able to ramp up and be more nimble on things like creating new tests for new viruses that arise, and the fact that we were rather delayed on that compared to other developed countries. All of that should and will feed into a holistic analysis of what went right, what went wrong in this country's response, and very importantly, what we can do to minimize the chance of this ever happening again, which can be difficult, as, again, being humble practitioner of healthcare here. Nobody could have predicted COVID or how COVID would evolve, but we can learn from it and minimize the chance of it happening again.
The federal response, it certainly is something we're going to need to know a lot more about. I wonder if you could tell us a little bit about that. I mean, how you found trusted partners you could work with in the middle of the pandemic. I know more about the emergency management side, and it was a little bit, well, terrifying, frankly, to see the administration sort of lurch from HHS to FEMA. And it was unclear, particularly last April, May, and June, I think, to a lot of people who watched this stuff closely, who was guiding the federal response. I wonder where you are in that context, in terms of interfacing with the federal government there. What agencies were helpful? Did you have to rely on your peers, maybe at the state level or in other cities? Who could you rely on?
I think it's helpful to start with the positive aspects of the federal response. So first of all, access to strategic national stockpile resources, including ventilators, but also PPE, that was made available to New Jersey, and we were direct beneficiaries of that. So for that, I'm grateful to the leadership at the time for really stepping forward on those issues. And also CARES Act assistance, the fact that we had a federal emergency bill that was passed that allowed for safety net institutions and hospitals to remain open at a time when we were not only contending with the worst healthcare crisis, but paradoxically also had the biggest strain on our financial performance in history. So that point was made as clear as possible to lawmakers, and they turned around a bill quite quickly, signed by the president, that allowed this hospital to continue moving forward, despite all of the financial stress that we were facing. And so those are positive aspects that I cannot not mention. However, the biggest issue, I believe, that made the U.S. Have worse outcomes than other developed countries is the lack of a central coordinated plan. I mean, if you look at President Biden's White House COVID team, the fact that it has representatives from almost every agency that's relevant, I believe every agency that's relevant, the fact that it has centralized folks who are focused on testing, on vaccines, on supply chain, reporting up to a single COVID coordinator who reports to the president. I mean, these are things that just by virtue of the organization and the whole of government approach has led to, I believe, a much better mobilization since January 20th on the things that matter. And I think the results are speaking for themselves. The goal for vaccination in this country was 100 million by 100 days, and now over 200 million by that time frame. I mean, literally doubling the goals in terms of performance. And so I believe that really underlies a lot of the issues around delays in getting tests to states, the fact that there wasn't enough testing overall, the fact that people were running out of PPE, which was unthinkable in a country with our level of wealth. All of those things stem from that.
I mean, that's an important point to underline there, that the leadership did seem to matter. I mean, it's a strange thing, and we go back and look at this, we're actually going to see sort of two pandemics from a managerial perspective. We're going to see one that was that, almost year of the Trump administration, and then whatever happens starting on January 20th. You've painted a really stark picture there. I wonder, I know it's no longer what your responsibility is, but you're pretty familiar with Veterans Affairs. I wonder what you've seen happen there in terms of taking care of veterans. That's an enormous health system, isn't it?
It is, and it's the largest health system in the country. I think, frankly, since the beginning of the pandemic, it's been a very, very good response. They not only responded in creating the surge capacity and making sure that resources were shored up, including staff. By the way, they hired tens of thousands of additional people by truncating the time required to bring new people on. And ultimately, they were able to meet the care needs of people. Not a single veteran was rationed care or didn't get treatment for COVID-19 if they got it. And they continue to have testing accessible to people, and they've been tremendous with vaccination. And so I think this is a clear example of public hospital system really stepping up and doing amazing things at a time of crisis. And so I think the next challenge will be sustaining those gains and making sure that as many veterans as possible are brought back into the system after many of them had to go to the private sector for care at the worst of it. And so I think a lot of that is on the agenda of the administration, and I think they're doing a tremendous job.
Just a reminder, you're listening to COVID Calls. I'm talking to Dr. Sharif Elnahal. I wonder if you could speculate a little bit about some of the changes we might see coming out of the pandemic at public hospitals across the country, and also in terms of medical education. I'd like to hear your thoughts on both of those.
I think the most important issue facing public hospitals now is a sustainable access to capital. You do your best in managing a hospital making sure you're providing excellent quality healthcare with the least amount of spending possible to be able to achieve that standard, to be able to maintain yourself. And so over time, you're lucky if you can just break even against a population, again, that has a high reliance on Medicare and Medicaid and charity care. And those are not high-paying insurances, and those are not payers that are necessarily sought out by private sector healthcare for that reason. And so ultimately, again, yes, you should be financially sustainable, and I think we've proven that we can be in the black as a public hospital financially. But that's still not going to be enough to finance a upgrade to your facilities, a new building, what have you. And I think it leads to the inequities. It has led to the inequities that you see in access to healthcare in communities that have an over-reliance on Medicaid and charity care, because those aren't high-paying insurances. So it all feeds into the lack of infrastructure that has developed over the years and has led to worsening of systemic racism and inequities in healthcare. And so I think a national policy solution to this is really important. Affording healthcare is a basic human right to communities in this country, despite their initial standing economically and the community that they live in, the zip code they were born in. I think that's a moral imperative of this country, and it's not solved yet. Medicaid expansion really helped. Before I got here, this place is going to go under simply because of the fact that 30-40% of the care here was charity care, which doesn't come to you for 2 years in terms of reimbursement. So, but that's not the only step. We need to do more to maintain the healthcare safety net infrastructure.
What do you see in terms of training for nurses and for doctors? I mean, I guess one way to ask this question is if you could go back and talk to yourself as a medical student, what would you need to know that wasn't taught when you were a student or a resident?
Yeah. So first of all, I'll just make a broader point that remember that institutions like University Hospital are the best places to train because you see the widest array of pathology and disease. And this isn't to be disrespectful at all in terms of meeting the mission and having a very high patient experience at this hospital. But it also just affords you the ability to take care of a wider array of problems and conditions. And so as a national imperative to have well-trained clinicians, we need to maintain these safety net institutions. And what I would tell myself is that, immerse yourself more in some of the social and systemic issues that people are facing in terms of your patients, because, to not have that background or knowledge and to probe why people are coming in with a medical problem from a system level would be to miss a big picture, a big part of the healthcare story of patients you're trying to serve. And so this whole idea, for example, of bringing more care to the community and housing homeless individuals and caring for them in the new home that you've offered them as a healthcare system. All these things are a few of many examples of how you as a frontline clinician can be an innovator and create a better system of care for the most vulnerable. And we need to do that as a country. It's not just affording the funding or access to health insurance, it's actually executing on the mission. And driving toward actually delivering that care to people, which is not trivial in terms of a task. We need the brightest minds looking at this, and to have equity as a centerpiece in that historical context, as a centerpiece of medical education, would go a long way there.
I'm glad to hear you sort of speak in those terms, but it sounds like in some ways a complete shift in the way that Americans think about what health care is. I mean, you used the phrase that it's a right, and you've talked about justice, and I wonder about that. I talked to lots of guests on COVID calls about that framework, and talking about healthcare and taking seriously public health, and the kinds of boasting that we do in the United States about what we can do in terms of innovation and medical research. But then there's less, or has been less, to boast about, maybe through this pandemic, about the public health system. And so everyone in America has dealt with this now. We've all seen these inequalities. I guess that's more of a comment than a question to you, just sort of underlying some of the things that you've said, but just put it back to you. This is the moment. It seems like if there's going to be one in our lifetime to make this case that this is a national imperative, this is it. So I wonder, maybe I draw you out a little bit more. Like, how are you going to seize this moment, Sharif?
It is the moment, and I'm so glad that you framed it that way, Scott, because I've been saying the same thing to our employees, our community. This is the moment for public health and health equity to either make a giant leap forward in terms of fixing some of these systemic inequities, or we can retreat back to the low trust environment that vulnerable communities and low trust situation in terms of how they perceive the medical establishment. And vaccination is big part of that moment, because we're telling people to suspend their disbelief and mistrust in the medical establishment and take a vaccine that was developed in less than a year. And I think there are very good reasons for that. I'm strongly pro-vaccination, and I've been out there telling the community to get vaccinated and encouraging more and more people to do that. But a frequent piece of feedback that I get is that, listen, if you can mobilize the will, the funding, the science to all work this fast and this effectively to combat COVID-19, which happens to affect everybody, not just us, what about, late stage breast cancer in Black women, or late stage colon and rectal cancer in Black people overall? What about chronic disease, which has plagued our community forever, and the fact that there isn't healthy food that's accessible to people, that's affordable. These are things that these are problems that are possible to solve, but there hasn't been any degree of comparable will, funding, and effort to be able to address them. And so we can either meet that moment and start chipping away further and further at some of these systemic root causes of inequities, or we can pretend like this didn't happen and retreat back to where we were before, which I believe would be very, very harmful to trust that we've tried so carefully to build with this community since the beginning of this pandemic. So I really hope it's the former. I hope that the mobilization around public health by the Biden administration continues, and all of that remains to be seen, but I'm optimistic.
We're almost up on time. Just one last question for you, and this is just about the hospital itself. There's been a lot of loss in the last 15 months. How are you marking that at the hospital? Memorial there? Do you have some practices that you've built in, some ways to pay tribute to those who've died and suffered during this time there at the hospital?
Yeah, we now have 12 deaths from COVID-19, physicians and our employees combined. And it's just really sad. Every death is a reminder of the gravity of the times that we're in. It also is an opportunity for us to mourn and reflect as a family here at University Hospital. And one way that we did that was to actually put a small tree for every person who died, and had employees write notes to the deceased, to their family, and hang those notes on those trees. And we gave those trees as gifts to the loved ones of our fallen University Hospital employees. And then we added, at the time, a 12th tree for anybody who would come after that time. And we're now, since we've had one additional person pass away from COVID-19, we have people hanging notes on that one as well. And so, it's something that was a small gesture, but got so much uptake. In addition to the shrines that we have for them in our chapel, the photos and everything for people to come and reflect. But we have to provide that space for our UH employees to really reflect and mourn, because these are folks who made it easier to get by, and were just such incredible colleagues and loved ones of people here.
Historians are listening, and I'm sure some of them are making notes right now and saying that the documentation project of what you've been doing there at University Hospital this last year of the pandemic is an important one, and it's such a crucial story to tell. Thank you so much for talking about those who were lost in that process of memorialization. It's really moving. Just want to remind everyone you've been listening to COVID Calls, and you can catch COVID Calls most weekdays at 5:30 p.m. Eastern Time. And I want to thank my guest, Dr. Sharif Elnahal, President and CEO of University Hospital in Newark, New Jersey. Sharif, thanks for making time. I know you're extremely busy, and for these insights that you shared today. I learned a lot. Thank you.
My pleasure, Scott, and thank you for doing these sessions. They're really informative. Take care.
Stay healthy, everyone. We'll see you tomorrow, 5:30 p.m. Eastern Time.